Rehabilitation of the burn patient begins on admission. Maintenance of function and mobility are best accomplished by prevention. Prompt, judicious positioning of the burn part to prevent contractures around underlying joints is maintained by careful application of dressings and splints. Comprehensive care of the burn patient includes appropriate positioning of the affected extremities during the healing process, prevention of joint contractures, therapeutic intervention to restore normal range of motion, management of subsequent burn scars, and patient education regarding therapy. During acute burn management, therapy should be instituted to prevent specific joint and regional contractures as part of a comprehensive rehabilitation plan. The modalities used depend on multiple factors, including the patient's medical status, level of consciousness and ability to actively participate in therapy, the extent of the burn injury, and current burn wound therapy. Early treatment is focused on preservation of joint motion and appropriate positioning of the affected part during burn wound healing. In addition to range of motion therapies, splints and positioning often are required after wound closure to overcome the adverse effects of wound contraction. Careful patient monitoring and adjustment of the rehabilitation plan are necessary to optimize the functional result. The functional importance of the hand cannot be overemphasized and thus receives special attention when burned. Functional outcome depends on the mobility of the entire extremity, and concurrent treatment of the elbow and axilla is required. Assessment of burn depth, edema, exposed soft tissue, hand dominance, and associated injuries is required to determine the most appropriate therapy. Splinting maintains the hand in optimal position for healing scar, grafts, and soft tissue structures, but it must be used in conjunction with a therapy program to prevent stiffness. Splinting modalities used depend on the phase of wound healing. Custom splints are manufactured most frequently from a thermoplastic material. The advantage of this material include the ability to adapt the splint to conform to wound dressings, ease of application and removal for dressing changes, their lightweight, resistance to moisture, and relatively low cost. The optimal position for the hand with dorsal burns is achieved with an intrinsic plus hand splint, with the wrist in extension, MCP joints in maximal flexion as tolerated, interphalangeal joints in full extension, and the thumb in abduction and opposition. The preferred splinting position for the elbow is in extension. This is accomplished with an anterior or posterior splint extending from the proximal 1/3 of the arm to the distal 1/3 of the forearm. During splint manufacturing, the patient is asked to hold the elbow in full extension with the forearm neutral. The splint must not be absolutely straight to avoid forcing the elbow into hyperextension with forearm supination. The optimal position for a patient with burns crossing the hip is with the hip in extension. Patients with burns crossing the lower abdomen and upper thigh seek a position of comfort with hip flexion. This positioning can be reinforced by lower extremity elevation, trunk flexion, and by an insufficient support surface while supine. The hip is not amenable to splinting, thus careful positioning, firm support surface, and early physiotherapy are required to prevent hip flexion contracture. The protective position for the knee is full extension. Patients with burns involving the knee area will frequently maintain the knee in a flexed position of comfort. Extension should be maintained with a posterior splint or knee immobilizer until the patient exhibits sufficient strength to fully extend the knee. Development of ankle equinus deformity can occur not only in patients with burns of the foot and ankle, but also in any burn patient who is non-ambulatory or otherwise incapacitated. This deformity can progress rapidly to a relatively fixed position resistant to therapeutic intervention, particularly in adults. Multiple modalities can be used to maintain the talotibial joint at 90 degrees and prevent ankle equinus. Prefabricated static splints are readily available, non-invasive, and easy to apply and remove, thus facilitating dressing application. Custom fabricated thermoplastic splints may also be used.